A child born in a neighborhood of Washington, D.C. can expect to live 27 fewer years than a child born just 10 miles away. Same city, same hospitals, same medical innovations, but radically different odds of survival. When someone hears that number, 27 years, they often think it must be a mistake. Maybe it's about personal choices. Maybe it's genetics. Maybe it's crime. But it isn't. It's more about sidewalks and grocery stores. It's about whether your neighborhood has trees or traffic. It's about whether a child grows up breathing clean air or diesel fumes. It's about whether a parent can see a doctor early or only when it's an emergency. 27 years isn't lost all at once. It's lost slowly, appointment by appointment, paycheck by paycheck, delay by delay. And once you see it, you can't unsee it. And I've spent most of my life trying to understand why. My name is Gowthamm Mandala. I was born in India and moved to the United States when I was just 9 years old. That shift across continents, cultures, and systems should have given me distance from inequality. But instead, it taught me something really uncomfortable. Inequality doesn't disappear when you cross an ocean. It just changes its accent. I come from the Dalit community group, a group historically labeled untouchable in India's caste hierarchy. For centuries, Dalits were denied education, denied rights, denied dignity. Many were beaten, segregated, or killed simply for being born into the wrong community at the wrong time. That history didn't just stay in the past, it shaped where my family could live, how people looked at us, and what opportunities we were told we didn't even deserve. When we moved to America, the vocabulary might have changed, but the feelings were familiar. Classmates wrinkled their noses at the food in my lunchbox. Kids made jokes about being Indian before I even knew what they meant. And within the immigrant community itself, caste found its way back into the conversations, as if it followed me through customs and stamped my passport. Living in both India and Indiana now didn't give me two different experiences of discrimination. It gave me the same experience twice, loud in one place and quiet in the other, but always present. And more importantly, it revealed a pattern. The same communities pushed to society's margins were the communities always pushed to the margins of healthcare. That realization is what pulled me towards medicine, not just as a form of science, but as a form of justice. Because when we talk about health, we love to pretend like the body is a neutral battlefield, that illness affects everyone the same. But the truth is, your health depends as much on your identity as it does on your biology. And we see this everywhere. In the United States, one of the wealthiest nations in the world, life expectancy still depends heavily on race, income, and geography. The Washington, D.C. statistic I mentioned isn't an outlier. In many American cities, from Chicago to New Orleans to Boston, neighborhoods just a few miles apart differ by 15 to 20 years in lifespan. Maternal mortality paints an even more painful picture. According to the CDC, the overall U.S. maternal mortality rate in 2022 was 22.3 deaths per 100,000 live births, but for Black women was 49.5, more than double the rate for white women. What shocks most people is this: a Black woman with an advanced degree is still more likely to die during childbirth than a white woman who never graduated from high school. That's not biology. That is the weight of structural inequity. And it's not just race. Research shows that social drivers of health, things like income, housing, education, environment, and transportation, account to 50 to 60% of health outcomes. Far more than genetics, far more than medical care. In a recent national survey, 12.5% of Americans said they delayed or skipped necessary medical care in the past because they lacked transportation, couldn't get off work, couldn't find an appointment, or simply couldn't afford it. These barriers don't show up on MRIs or blood panels, but they determine who gets care early, who gets care late, and who doesn't get care at all. I see this reality up close as an emergency medical technician in Indiana. A story that I remember, a call that still stays with me, is we were dispatched for a middle-aged man struggling to breathe. And when we arrived, he was sitting on the edge of his bed trying to stay calm for his kids. His inhaler empty. He told us that he'd been stretching it for weeks because the refill cost too much. And as we loaded him into the ambulance, he kept apologizing, not for being sick, but for being a burden, a problem. That moment has never left me because no one should feel guilty for needing to breathe. And yet systems had taught him that survival itself came with shame. That's what inequity looks like in real life. It's quiet. It's normalized. It's accepted until it becomes an emergency. Furthermore, I've walked into homes where a parent skips their medicine so their child can eat dinner. I've treated people who ration their insulin because they have to choose between staying alive or staying housed. And similar to the story above, I've had patients apologize for calling 911, not because they were in pain, because somewhere along the way, they had learned that their suffering is less important than someone else's. None of these moments are failures of individuals. They are failures of systems. And yet, I've also seen what happens when the systems do the opposite. When they meet people where they are. A translated discharge sheet prevents a dangerous readmission. A community clinic catches hypertension before it becomes stroke. A needle exchange program stops an infection before it starts. These interventions are simple, they're proven, and they're powerfully effective. They're not miracles, they're just fairness. So people often ask me, what does health equity actually mean? And the simplest answer is this. Equality gives everyone the same thing. Equity gives everyone what they need. If two families live 20 minutes away from a hospital, where one has a car and the other has to take 2 buses, their access is not equal. If 2 children have asthma, while one grows up breathing clean air and the other grows up near industrial pollution, their disease is not equal. And if 2 patients need surgery, but one can take time off work and the other risks losing their job, their recovery is not equal. For some people, the word equity makes them uncomfortable. It can sound like favoritism, like giving someone more than they deserve. But equity isn't about advantage. It's about fairness in a world that isn't fair to begin with. Treating unequal conditions as if they're equal doesn't create justice, it preserves harm. Equity simply says this: if we truly believe every life has equal value, then our systems must reflect that belief, not just in words, but in practice. Equity recognizes these differences and actively works to close the gaps. So how do we get there? From my experience in ambulances, in classrooms, in legislative meetings, and in community conversations, I believe we need 3 commitments. First, we must listen before we treat. The most powerful diagnostic tool we have isn't a machine or a lab test. It's the patient's story. If we don't understand someone's environment, their barriers, their fears, and their lived reality, we cannot understand their health. Second, we need to remove the barriers we already know exist. We don't have to guess what works, because we know that community health workers reduce hospitalizations. Transportation programs reduce missed appointments. Affordable medication programs improve chronic disease outcomes. And language access improves safety. These solutions have decades of evidence behind them, and we simply need to be prioritizing them. And third, we need to build systems with and not for marginalized communities. Equity cannot be imposed from the top down. It must be co-created by the peoples most affected. That means representation in leadership, representation in policymaking, in medical education, and in the design of every system intended to care for humans. My own life reflects these commitments. I serve as an EMT. I advocate for equitable healthcare and career and technical education at both state and federal levels. I founded a nonprofit, Echo for Equality, to amplify marginalized voices, and I serve as the International Post-Secondary Collegiate Board Representative for HOSA Future Health Professionals, representing thousands of students across the country and the world. Everything I do circles back to one purpose: building a world where health isn't guided just by science, but also by justice. I believe we're at a turning point right now. Technology is advancing faster than ever. Medicine is becoming more precise, and data can predict risk before disease appears. But none of that will matter if our values don't catch up with our tools. The question isn't whether we can build a more equitable healthcare. It's whether we choose to. Whether we are willing to design systems that see people not as problems to manage, but as lives to protect. I stand here today as someone whose ancestors were told their lives had no value. I stand here today as an immigrant who learned that discrimination doesn't just vanish, it evolves. And I stand here as someone who refuses to accept a healthcare system where your odds of living or dying depend on your identity. The statistic I opened with, 27 years of life lost, depending on your address, should not and cannot exist in any society that claims to value fairness. And the only way we can eliminate that is by recognizing that health isn't just a medical issue, it is a moral one. So tonight, I want to leave you with this, an invitation to imagine a world where healthcare doesn't reflect our inequalities, it corrects them. Where a person's life expectancy isn't determined by their race, their caste, their income, or even their zip code. Where dignity isn't earned, it is guaranteed. When we stop asking who matters and finally answer everyone. That is the world I am working towards, and I really hope you'll join me. Thank you.